Okay, good afternoon, everyone. Thank you for joining today's webinar. My name is Ethan Hunt. I'm an assistant professor here in Health Promotion and Behavioral Sciences at UTHealth School of Public Health in Austin. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UTHealth Houston School of Public Health. The center's vision is healthy children and a healthy world, with a mission to advance health and healthy living for children and families through early and impactful interventions. Thank you to the Michael and Susan Dell Foundation for providing funds to the center to host today's webinar. Additionally, information about the center's work and resources can be found online. Please scan the QR code on your screen to access our health resources. The slides and recording of today's webinar will also be archived on the website, msdcenter.org. If you have any questions during the presentation, please enter them in the question chat box for the Q&A session at the end of the presentation. And with that, I'm excited to introduce our speaker, Dr. Christopher Pfledderer. Dr. Pfledderer's work involves finding ways to optimize the scale up of child obesity-related interventions from both implementation and translational perspectives, with specific expertise in school-based physical activity promotion, serving as both a researcher and former K-12 teacher. He aims to enhance behavioral interventions in rural communities. His current focus has expanded to identifying how context influences the 24-hour movement cycle. I'll now hand it over to Dr. Pfledderer with his presentation entitled Health Promotion for Children in Rural Settings.
Thanks so much, Ethan, for that introduction, and thanks to you all for being here today. Like Ethan said, my name's Chris, and today I'm going to be presenting on health promotion for children in rural settings. We're going to start today by reviewing some basic definitions of rural, and then we'll mainly talk about obesity and obesity-related health behaviors today among youth in rural United States. And I'll present some statistics on both obesity and those related health behaviors with urban comparisons. Then we'll discuss some strategies to improve rural health promotion efforts for kids in these areas. And then at the end, I'll give you some rural specific resources if you're interested in those, and then we'll have some time for Q&A. So the first question we want to answer is, what is rural? And there are a lot of definitions for rural in the United States. So the US Census Bureau doesn't define rural per se, but what they do is they consider rural to include all people, housing, and territory that are not within an urban area. So any area that is not urban is rural. And you can see the urbanized and urban cluster definitions down there. They base it on count of population. With this definition, about 20% of the population, or 59.5 million people, live in a rural area in the US, and 97% of the land in the US is classified as rural. If we look at the Office of Management and Budget, they have a different definition of rural. They decide which counties are metropolitan, metro, or micropolitan, or neither. And you can see that their rural definition is a little bit different. So they use the terminology metropolitan or micropolitan or neither. With this definition, about 46.2 million people live in non-metro counties, and that's about 15% of the population, and that covers 72% of the land area of the country. So a little bit smaller percentage than the US Census Bureau's definition. Another more detailed definition of rural are these rural urban commuting area codes. Sometimes you'll hear them pronounced RUC codes. And what they do is they have a 1 through 10 classification. So it's kind of on this continuous scale. Typically, classifications 4 through 10 are considered rural. These are the classifications that I use and a lot of other rural researchers use because it gives you a much more detailed definition of what rural is. And you can kind of choose how rural you'd like to go. So if you want to do research in all 4 through 10, you're still doing rural research. But if you want to get more detailed, you may choose only to focus on those that are categorized as 9 and 10. The interesting thing about rural definitions is that there was this review done by Childs, Boyce, and Blackburn a few years ago, and they looked at how rural was defined in the United States alone. And what they found is that there are 33 different definitions of rural used in the US. And that can have implications for health outcomes as well, if you use one definition versus the other definition. And there are even papers that have looked at how using different definitions actually changes estimates of things like obesity and health-related behaviors. So it's really important if you're doing research or if you're doing policy work and you're working in rural communities or rural areas, that you have an idea of what that rural area means. How are you defining it? How are you identifying folks that live in those rural areas? Again, this can have larger implications. So this is the Grand Canyon. There are certain definitions of rural that actually categorize the area around the Grand Canyon as urban, which is kind of surprising. So it's really important to understand what definition you're using and know how that influences the outcomes that you're looking at. The next question we'll answer is, where is rural? So this is obviously a map of the United States, and we can see where rural is in the US. And if you remember back to my previous definition of rural, it can be anywhere from 97 to 70% of the land in the US. That's not accounting for population, but if you look at all the areas in green, those are considered rural areas in the United States. What we're going to focus on today is obesity and obesity-related behaviors. This is a breakdown of obesity prevalence in the US by county. And if you average all the counties in the US, we're sitting at about 33% those who have obesity. If we break this down by metro and non-metro, if we look at the average across metro counties, it's about 29%. And then if we look at the average in non-metro counties, it's 36.3%. So we have much higher obesity rates in non-metro rural counties than we do metro urban counties. I wanted to bring this up too. We are just focusing on obesity-related health behaviors today, but there are many, many other health-related issues that I am not going to discuss today. Some of these include alcohol and substance use, tobacco use, mental health, injury, cancer, stroke, and respiratory disease. So we see these large differences many times in these other health outcomes, particularly with substance use, mental health, and injury. Like I said, today we're going to focus on obesity-related outcomes. I've categorized them into 4 since I do a lot of 24-hour movement behavior research. Most of the outcomes that I focus on are physical activity, sleep, and screen time, sedentary behavior. We will discuss diet briefly as well. So this data that you're looking at comes from the National Survey of Children's Health, which is a nationally representative survey of children across the country. And this is specifically children, so 6 to 12-year-olds. But what we can see is a breakdown of who is meeting guidelines. And we've categorized it into physical activity, sleep, and screen time. And the way you read those 3 circles across the top is up here in the purple, you can see in the top circle, 21% of children in the US are meeting physical activity guidelines. 66, 68, or 67% are meeting sleep guidelines, and 47% are meeting screen time guidelines. And then when the circles overlap, that is the percentage of children who are meeting both guidelines. So for example, if we stick with the purple circles, we can see that about 15% of children are meeting both the physical activity and sleep guidelines. 13% are meeting physical activity and screen time. 33 are meeting sleep and screen time. And then if we look right in the center, that's the percentage of children in the US who are meeting all 3. So they're getting 60 minutes of moderate to vigorous physical activity a day. They're getting 9 to 11 hours of sleep per night, and they're engaging with recreational screen time less than 2 hours per day. So about 10% of children in the US are meeting those recommendations. Now, if we look, it's probably easier to focus on the bar graph at the bottom for these urban-rural comparisons. But what we've done is we've statistically compared the proportion of children who are meeting guidelines between urban and rural. And we see some really interesting things. So first off, we see that the proportion of rural kids meeting physical activity guidelines is significantly higher than the proportion of kids who live in urban areas. We also see that sleep and screen time, a lower proportion of children in rural communities are meeting sleep guidelines compared to urban. But we do see that a higher proportion of rural children are meeting screen time guidelines. So we have some really interesting differences here that we'll kind of get into in today's talk. But still, if we look back up at the circles, you know, only 20 and 27% of kids are meeting physical activity guidelines, depending on whether they're urban or rural. In rural communities, about half are meeting screen time guidelines, and still only 12.8% are meeting all guidelines. So these are some issues that we really want to address in rural communities. Even though from this study, it looks like children in rural communities are doing a little bit better in terms of their guidelines, most of their guidelines than urban children, we still have a really, really low proportion of children meeting guidelines. Another interesting thing is if we look at the associations between meeting the guidelines and overweight and obesity. And the blue is children from urban communities, the green is children from rural communities. And what we see here is that the odds of having overweight or obesity are significantly lower for rural kids who meet the 24-hour movement behavior recommendations. However, if we look at the blue circles with their 95% confidence intervals, those lines right there, we see that there are no significant odds of having overweight or obesity or not having overweight or obesity. So what this tells us is that 24-hour movement behaviors, if we promote them in rural children, they may have even a greater impact on the odds of overweight or obesity compared to children who live in urban environments, which is a really interesting thing. I also wanted to review some other studies as well, not just the ones that I'm doing, but this was a study that compared physical activity from baseline, which was pre-pandemic, to during the pandemic. And what we see here is that at baseline pre-pandemic, folks who lived in urban areas had higher physical activity compared to rural residents. And then during COVID, what happened is that the urban residents' physical activity decreased such that the urban-rural differences were non-significant. So it almost seems like the pandemic had a flattening effect on the differences in physical activity between urban and rural residents. This is a large table. I just want to focus on one thing here. It's the sleep guidelines. So this comes from another study that we're doing with the National Survey of Children's Health. The percent of rural children meeting sleep guidelines is significantly lower than the percent of urban children meeting sleep guidelines. So we do see those differences, even though some evidence may say that they're more physically active and they have less screen time. Sleep is still an issue with rural children. And then in terms of diet, the evidence is kind of mixed. So this is a review that came out, wow, 10 years ago now. And what they did is they looked at both physical activity and diet among rural and urban children and adolescents in the US. And you can see I just kind of did a quick summary of the article for you, but 2 of the studies showed no difference between rural and urban youth. One study showed that rural children consume more calories than urban children, and we have some back and forth there. So I think the evidence on diet is still out. So now that we have kind of an idea of some basic statistics, I certainly didn't cover all the studies out there on urban and rural differences. among obesity-related behaviors. But we also really want to understand why this is happening. Why are there differences not only in activity levels and sleep and screen time, but also obesity rates, because we know that the obesity rates are higher among rural children. So I always like to take the socio-ecological approach. Many of you on the webinar probably already know of this approach, but we see that it's a multi-level approach to understand health behavior. And I think that we could go back and forth all day and pick any one of these variables here in this figure and discuss the urban and rural differences. I want to focus on one, which is the built environment. So this is another nationally representative study that we're working on, comparing some of the perceptions of neighborhood environments between urban and rural residents. And what we see is that rural residents seem to perceive neighborhood safety a little bit higher than their urban residents. So we look to the left, the percent that definitely agree that their neighborhood is safe is 73% compared to 65% of urban residents. We also see the same thing with neighborhood support. So rural residents perceive that they have a supportive environment more than urban residents, 64% compared to 55%. But, and this is, I think, a larger issue here, is if we look at neighborhood amenities. So even though, if we go back here to support and safety, even though rural residents may perceive safety and support higher than urban residents, the number of neighborhood amenities that promote things like physical activity and getting outside, being active, maybe getting off screens, those number of amenities are much lower in rural areas compared to urban areas. So 25% of rural living kids and adults reported that there were no neighborhood amenities, no parks, no playgrounds, things like this. While 37.8% of urban residents said that they had all four. They had parks, they had playgrounds, they had sidewalks. So even though in rural areas, people may perceive their neighborhood to be safer, more supportive, the infrastructure that is needed to promote healthy lifestyles is just not there. And despite some of the limited evidence that I talked about today that shows youth in rural environments may be more physically active and less sedentary than youth in urban environments, the crux of the issue, aside from neighborhood amenities and things like that, is that if we look in the literature, we still lack effective evidence-based obesity-related intervention that are delivered specifically in rural communities. And this is an issue because we still are sitting at 36% obesity prevalence in non-metro counties. And even though it may be some of these guidelines, the proportion of kids meeting guidelines may be higher in rural areas, we're still sitting at less than 13% of kids in rural environments who are meeting 24-hour recommendations, these obesity-related health outcomes. So let's review some evidence on this. Why, what are the numbers in terms of evidence-based obesity-related interventions? So a while back, we did this systematic review. I come from training. I'm a school-based physical activity researcher during my PhD, and so we did this review looking at different type of evidence-based interventions that have been delivered in schools to promote physical activity. And what we did is we compared those interventions that were delivered in urban schools versus rural schools. And we found some sobering differences here. We found 28 evidence-based interventions, school-based physical activity interventions that were delivered in urban environments, but we only found 5 evidence-based, school-based rural interventions. And so not only are they low quantity, but if we look at the mean baseline sample size, the middle blue bar, we see that for urban interventions, they had a mean sample of 1,605, and the mean baseline sample for school-based interventions in rural areas was only 283. So low quantity, limited reach. And then also, if we look at the number of components that were in each intervention, so many school-based interventions will be multi-component. Maybe they target recess, classroom, physical education, walking and biking to school, things like that. So if we look at this and we look at the number of components, there were far more multi-component interventions delivered in urban settings compared to rural ones. So at least in this sphere of research, school-based physical activity interventions, there's fewer being delivered in rural settings. They have smaller reach, limited reach, and they also have fewer components. And so one thing that I really like to do, this article from Renee Meyer came out in 2016, and it's a rural call to action. They're actually working on an update to this right now. But I really like these two lines, and when I was reading it for the first time, it shaped the way that I think about designing and delivering obesity-related interventions in rural communities. So we'll focus on this first point in the beginning. So the authors say, this conceptual fallacy often emerges as investigator-derived rural strategies to target physical activity behavior treat rural communities merely as small urban ones. And what we do is we transpose what is known from urban literature to rural settings. So we're taking an evidence-based intervention that has maybe done well in an urban setting, and we're bringing it over to a rural setting, and we're expecting that to work because, hey, it worked here in the urban setting. Sure, it's going to work in the rural setting. But what we see in the literature, that's not almost ever the case. And I want to explain this in a little bit more of a scientific way here, why this happens. So this is a study that came out a few years ago from researchers at the University of South Carolina. This is where I did my postdoc, so I know a lot of the researchers here. And they did this really interesting thing where they looked at something called risk of generalizability biases. And what those are certain things that are present in a pilot study that may or may not be present in the full-scale, larger efficacy trial. And what they did is they compared effects, behavioral outcomes between pilot studies and the scaled up version of that pilot study. So they went back through the literature and they found the pilot study, and then they found the larger study that came from the pilot study, and they compared effects, and they also compared things like who was delivering the intervention in the pilot study compared to the larger study. What was the level of implementation support in the pilot study compared to the larger study? Who was the target audience? What was the setting? What was the intervention duration? And they looked at these differences. And what they found was that when certain things are found in the pilot study, maybe the pilot study has really, really high implementation support. And then the pilot study works as intended. However, now it gets scaled up a few years later, and the study staff can't provide as much implementation support. And when this happens, because of that difference in implementation support, we may see the effect of that intervention drop. What we call it is voltage drop. And where this comes into play for this webinar is setting. So if we focus specifically on setting, we see that when we change the setting from a pilot study to a larger scale study, huge voltage drop. And I think that this has implications for how we deliver rural studies as well. So if I pilot something in an urban setting and it goes really, really well, and then I try to deliver that same study scaled up in a rural setting, we may see a lot of voltage drop. My intervention no longer works or has the hypothesized effect on my health outcome. So I think that that's one of the major issues that we see today. The second part of this quote that we'll focus on is, although urban-derived strategies can be a helpful starting point for conceptualization, it's important to consider rural America as a distinct type of setting that offers unique opportunities and challenges for active living. So what they're saying here is that A rural setting and an urban setting are unique, and it has unique opportunities. It has unique challenges. There are different barriers and different facilitators here. And preferences and the efficacy of intervention components may be different. So how can we tap into that as researchers? One thing that we can do, one thing that we've done in the past, is this thing called a discrete choice experiment. So this is a technique that was actually started in market research. So marketers use these types of discrete choice experiments to understand people's preferences for certain things. So, let's say a company was trying to design a car. Well, they may give out a discrete choice experiment and understand what components of a car are most important for people buying that car. You can do the same exact thing for intervention components, and this is what we did here. So we compared parent preferences for physical activity in before and after school programs in rural and suburban communities. So we had a group of rural parents, we had a group of parents who were in a suburban community, and we gave them this discrete choice experiment. And what we did is we came up with a certain number of attributes. So, what time of day would you like your program to be delivered? Do you want it before school only, after school only, offered before and after school? What should be the main focus? Is it only focused on physical activity? Is there some time for academics? Is it a balanced mixed? And so on and so forth. So we talked about leadership and goals and length as well. And then within that discrete choice experiment, what the participant is shown is a menu. So you get two different menus per se of your components. And what you do is you select the one that you would prefer most. And they're given a mix. There's like 30 different ones, and then you mix and match all the different components, and participants will select one or the other. And then in the end, what you can do is you can get an idea for what component and what factor participants like the most. So not only will you get an idea of, okay, we really need to focus on time of day, but you can also get an idea of, also, parents prefer a before and after school intervention compared to an after school one. So it's a really neat way to do these comparisons between different subgroups. And what we found was that the time of day a before and after school program was offered really influenced rural parents' choice more than suburban parents' choices. And what we also found was that rural parents wanted the main focus of the program to be physical activity, and parents in suburban neighborhoods really preferred a program that was an equal mix of physical activity and academics. So we start to see these differences, and we could add more and more components to this to really understand preferences. The other thing I'll say about these discrete choice experiments is that they've been shown to not only, measure preference, but also the likelihood that someone's going to enter your intervention. So it's not enough for them to just say, hey, we would like this one, but there's been follow-up studies that have shown that if you design something based off of a discrete choice experiment, your recruitment levels and your retention levels may be a little bit better than if you didn't. So this is one strategy to do that. The last thing that I want to leave you with, and then we'll have time for questions, is some of these resources here. This is from, Renee Meyer, who wrote that piece, the Rural Active Living Call to Action. Their website at Baylor has some really great rural specific tools that you can use if you're, a researcher, policymaker, whoever. And I've used these tools before. So they have, one thing that I've used before is this rural active living assessment. So it's a built environment assessment, but it was developed specifically for rural communities. So there are certain things within this assessment that are different than what you would find in just a regular built environment assessment. And it's a really nice tool to use. I've used it in funded projects before. I've used it to go out into the communities and see what resources are available, how people are utilizing their resources, what are the specific barriers and facilitators to active living. It's a really great tool. And then not only do we have an objective measure, a rural specific objective measure of the built environment, but we also have this really nice perceived environmental support scale that was designed again specifically for participants in rural communities. So it asks questions that are very rural specific. And whenever we're doing rural research, I really recommend, if it's available, to use rural specific tools. So those are some great resources. The hyperlink at the bottom there will take you there, but you can also just type into Google rural active living measurement tools, Baylor University, and you'll be taken to this site. The other resource that I use quite a lot is this Rural Health Information Hub. So the website is down at the bottom, ruralhealthinfo.org, but it's a really nice resource for both people who do rural specific research and those who would like to start. And one tool that I use all the time, especially when I'm scouting locations for projects, or I'm working on a grant and I'm deciding what areas I want to be in, is this Am I Rural tool. And what you can do with this tool is you can put in any address in the United States, and it will give you, remember how we talked about there's 33 definitions of rurality in the United States. It will give you most of those as a printout. And you can get an idea for things like population statistics, land size, and it'll give you a nice indication of, depending on the classification scheme that you're using, what is rural and what is urban. So I encourage you to go to this Rural Health Information Hub if you want to understand a little bit more about what's categorized as urban and rural. And then they also have some really nice rural specific funding announcements as well. They have a list of rural specific grants if you're interested. Go to ruralhealthinfo.org. I'm not affiliated with this Rural Health Information Hub. I just use it a lot, so I wanted to give you all that as a resource. And then the very last thing I'm going to end with is something that I do when I lecture about this with my students. Sometimes what I'll do is I'll go on like Google Maps or Maps, and you can see the street view of certain things just to get an idea of different environments. And it's really interesting to see these environments, how they change and how they're similar, not even in the United States, but globally. So this is a Google Map street shot of a rural area in Ethiopia. But if you go just an hour north of this, this is a Google Street View of Ethiopia. And the reason I bring this up is because the continuum between urban and rural is very fine. And the differences in rural and urban environments can be extreme in some places. So just keep that in mind, especially if you're doing global work, that rural areas and urban areas can look distinctly different. But even within in the United States, rural areas are all over the place in terms of how they look, what resources are available to them, and so on and so forth. So this is an example. This is Mackinac Island in Michigan. This is considered a rural area. And if you've ever been to Mackinac Island, there's no cars, and so the infrastructure for biking and walking is just top notch. And this is kind of an outlier in rural areas in the United States. You're never going to get something like this anywhere else in the rural U.S., but it's still considered rural. This is another interesting one. So if you took out the Mongolia piece there, I kind of buried the lead. But if you just looked at this street view, you would probably think, oh, this is just any town in rural America. It's got a little pizza shop. It's got some buildings, some houses. But this is actually a street view of Mongolia. And so even though Mongolia is a world away from the U.S., some of these things might be very similar across settings. So it's important to keep that in mind as well. And then this is a very traditional one. This is actually my family farm where I grew up in the United States, which is considered rural. And this is probably people's traditional view of rural, with cornfields and dirt roads and things like that. But the reason I bring that up again is just to remind us that there are huge differences in the US when it comes to urban and rural, but then even in rural, there are huge differences. So I kind of painted this broad picture with statistics, but they're very diverse areas. Thanks again for tuning in. I hope this was engaging and helpful to y'all. And at this point, I think Dr. Hunt is going to lead the question and answer session. So Dr. Hunt, I'll give it to you.
Okay. Thanks, Chris. Yeah, so we're going to answer questions from the audience that have been coming in. I'll filter through some and let you go ahead and answer those while I am filtering through more. So just an admin quick comment on admin. Yes, the slides will be shared at msdcenter.org after the webinar, as well as you should get an email about your CHES credits too. So just keep that in mind. So firstly, Chris, I like this one. This person said, what is your preferred definition of rural? Because we mentioned how many there are. And do you have to switch between these definitions depending on your research question, or, and I'm adding this, grant proposal as well?
Yeah, so to answer the first part of that question, I always use RUC codes, those RUCA codes. Once you get the slides, you'll see, it's a 1 through 10 scale. The reason I like to use those RUC codes is because it's a very, very clear definition of what is rural. And the other thing that you can do is, since it's a nice continuous scale, you can kind of look at that scale within your research questions. So what are the differences between a community who's considered a 4 versus a community who's considered a 10, which is, remote rural. So I always use the RUC codes, and I always give a range. Typically, I focus on communities that are categorized as 6 through 10. 4, you're still getting into, they're essentially suburban environments for the most part, not always, but the higher the number, the more urbanicity you see. So I tend to go a little bit more rural on my scale when I'm focusing on grant submissions. The second part of the question, does that definition of rural have to change? Yes, it does. So if you're doing more epidemiological work where it's not community-based, you may choose to use county classifications instead. That might be one reason that you would need to change your definition of rural. But what I'll stress is that whatever definition you use, especially if you're a researcher, I read a lot of rural research, and many times folks will just say, this intervention was delivered in a rural community, but they don't necessarily give a definition for how that community was defined. And that's really important. So whatever definition you use, please do give some information about how rural was defined, and then a justification for why you're using that definition as well.
Great. Here's another one. You mentioned a few examples from your school-based work that you've done in the past. Can you touch on some of the current challenges that you see with school-based interventions delivered to students in those rural communities?
Sure. So that kind of goes back to the slide I had with the urban and rural comparisons and school-based activities. One thing is reach. So for the most part, rural schools will have fewer children. However, the amount of area that school serves is often much larger. So if I go to a rural community, a school district may only have one elementary school that's serving that entire school district. If I go to an urban community like Austin, where I'm at, a school district may have 12 elementary schools serving a very tight section of the community. So we call those catchment areas. Catchment areas in rural schools tend to be a lot larger. So you're getting, yes, more land, but one issue that we see is the distance between a home where the child lives and the school is much longer in rural communities. So I've gotten into situations before where I may be delivering an after school or before school intervention, and it's very difficult to recruit and retain participants just because parents sometimes may have to drive an hour to their school. I've done research out in Utah where the school served students who were living an hour and a half away from their school, and that was just their catchment area. So distance is a really big barrier. And then the other thing that I'll say is, and I think this actually probably applies to any school-based research, but sometimes, well, all the time with school-based research, it's important to find a champion in the school who's going to be your advocate, because you aren't in the school every day as a health researcher. And many times those champions are school teachers. And what we see is that teachers, they come and go, that there's a high attrition rate with teachers. And if you lose your champion in the school, a lot of the time your intervention can fail because that person isn't there every day. And so I think it's important when we're doing this school-based research to not rely on just one person, spread the burden, I guess, if you want to call it, out on multiple people or a committee of people. So if one person leaves or whatever, your program can still go strong.
Great. So here's another question that may be a little bit outside of your research area, but I know a little bit about the evidence base on this question, so I can contribute too. This person says, can you discuss the difference between rural and frontier healthcare areas? In particular, this person works in Amarillo, where they serve many large counties without hospitals. Is that really the main difference? They're asking no healthcare providers at all. So I know just briefly from the adult literature base, yes, when you have these large counties without hospitals, it does significantly affect health outcomes. Whether it's because of reduced access to emergency care, longer travel times, like you were just mentioning with schools, to reach these medical facilities, delays in receiving treatment, among others. So I know that in the adult literature, yes, they have found that this can lead to poor health outcomes and increased mortality. So do you want to add anything more to that particular question, Chris?
I think you basically covered it. The one thing that I'll say is, there was a slide where I listed a bunch of other health outcomes that we weren't talking about, but one of those was injury. Job site injury, sports-related injuries, things like that. And there's been studies out there that have shown it's, not only is it the type of work that rural residents may be doing, but it's also the distance to these facilities. So if you get injured, it's the difference between a 5-minute drive to a hospital if you're in an urban environment sometimes, and an hour drive to a hospital. So that contributes to all sorts of health outcomes in rural communities. Yeah.
We still have some more time, so I'm going to go ahead and slide to another one here. This person said, are most health behavior data on rural children self-reported? Is this largely a function of how challenging it is to collect that data in these environments?
Yeah, this is a great question because it's something that I didn't bring up, but the answer is yes. There are studies, of course, out there that have done objective measures of things like physical activity and sleep, and even overweight, obesity, but largely it is self-report. And so we should take some of the statistics that I showed, because those are self-report statistics. We should question those a little bit. The difficulty there is, if we think about someone who's doing research, population health research, things like that, most of the time they're in an urban setting, they're at a university, and to travel out and get to participants in rural communities can sometimes be 2-3 hours. And if you're doing multiple measurements and multiple time points, that distance alone can be a really big barrier for how you operate your research. So yes, there are less objective data on rural residents compared to urban residents, for sure.
Yeah, this person says, if you had to pick, and this is probably something you just mentioned, any priorities that you would like to prioritize that would move rural health promotion forward, any idea of a couple of what those would be?
Yeah, I think if you're interested in rural health promotion, and I come from the research side, but if you're interested in that, and you're having these doubts about, oh, it's going to be really difficult to reach folks, and in rural areas and my recruitment and my retention, I urge you to at least try. You will find, at least in my experience, that working in schools, working in rural schools, you're not saying that urban schools don't have this, they do, but the communities there, at least in rural schools, are so open to trying new things and so supportive. And many times they're tight knit. And so if you want to do research in these rural environments, I would say try to find some advocates in the community that will help you, because if you're not living there, you're not there every day, you're at work. Um, and the other thing I'll say is try to give back as much as you can to these communities. So, don't just go in and collect data and then say bye. Really try to give back and make an effort to go out and improve health there in those communities. And even if your funding period ends, keep in touch with the folks who've helped you out during your programs in rural areas. So yeah, I think that's one priority, is people who are just starting to get into this kind of stuff, rural health. Just try, and I think that you'll really enjoy it. The second thing that I'll say is I think we really need to take a look again. I mentioned this in my presentation, but how health behavior interventions are designed and delivered in rural communities. So in some cases, it may be okay to take an evidence-based intervention that was delivered in an urban setting and give it to rural residents. But in many cases, it isn't. And so, if you're trying to find a quick program to use, and whatever your health behavior is, let's say you have this evidence-based intervention, but if you look at the intervention components, there may be things like built environment or clinic visits, or things like that, where we see these differences in urban and rural communities. Do your best at doing some co-development with folks in those communities and some adaptation. I think adaptation is the biggest thing that we can do right now for rural interventions.
Yeah, I definitely think the co-development is an important piece there, especially within those rural communities. I think this may be our last question, and then I'll follow up with a couple admin items too. So this
Okay.
person is asking about online resources. Do you think that, and maybe you have some best cases that you could talk about on how online resources can help reach rural areas if access and driving to these areas is a barrier?
Yeah, I think it's a good point. If you were to ask me that 10 years ago or so, I would say you're still going to have some difficulty with online resources just because of cell phone coverage and internet. But anymore, we do see that, almost everyone has cell phone coverage and internet. And so I think online resources can be really helpful. I think it's a great way to disseminate information quickly, especially if you are, like I said, 3 hours away in an urban environment and you're trying to deliver some program to folks who live really far away from you. I don't think that can be the end all be all. I think for these health behavior interventions to work, there does need to be some multi-component nature to them. So, sending out newsletters and reminders and things like that. Maybe there is some sort of mHealth intervention that would be good for you to use, and that could be delivered online. But I think a core piece of this is really going into those rural communities and doing things in a multi-component way. The one plus to some of the online communication is that there's constant contact now, and so you can get this information out quicker and to a wider range of people. So that is always helpful. But again, I think multi-component should be the way to go.
Yeah, and sorry, one more came in because we're still a little ahead, so I'll go ahead and mention this one. This person says, have you worked with homeschools or co-ops? And the only reason I wanted to touch on this because I think nationally the rates of parents homeschooling their kids has gone up in recent years, and I know it has in Texas, especially where I live in the North Austin area. More kids are doing homeschooling and co-ops. Those are urban areas, but have you heard anything about what's occurring under that homeschooling umbrella within rural areas? And that could be a potential area of research as well.
Yeah, I have not. I think it is a really interesting area of research. And Ethan, you mentioned it's not just in rural communities. It's getting very popular in urban communities too. It's something that I haven't focused on yet, but I think if the trend keeps going like this, it's really something we need to pay attention to. Yeah.
And with that, we are a little early, but that is all the questions that we have. So I want to thank everyone again for attending the webinar. Again, the slides and even the resources mentioned will be posted on msdcenter.org, along with information on upcoming webinars. Also, you will receive the follow-up email with links for your CHES credits as well. So thank you for joining us today, and we will see you next time.